So the title of the talk is Women and Heart Disease. And is her heart or your heart different than his? So I'm going to start off with a couple of facts and a couple of statistics first. Cardiovascular disease is a leading cause of death in women regardless of age, regardless of gender, races, or ethnicities. Across all racial groups, cardiovascular disease is the most common cause of death. In women, 1 out of 3 deaths are due to heart disease. So there are more deaths from heart disease among women than stroke, more deaths from heart disease than lung cancer, more than COPD, or chronic obstructive pulmonary disease, and more than breast cancer. And in fact, the deaths from heart disease are more than all of those diseases combined. So here is a graph of mortality in the United States from heart disease. The red line is the deaths, the total number of deaths represented by women. And in the blue line, you see cardiovascular deaths among men from 1979 to 2000. And what do you see there? You see that from 1980 onwards, the cardiovascular deaths for men are dropping and dropping and dropping. By about 1984, the cardiovascular deaths for women are climbing to the point where they're 2 times, 3 times, 4 times greater than that of men. So what's going on here? Why is it that women die of cardiovascular disease and are increasing to die at higher numbers compared to men whose mortality is dropping? What's really important about the figure I just showed, and what's really important about the fact that more women are dying, is that 80% of all heart disease is actually preventable. So what is different here that we're not doing the same things for women that we have traditionally been able to do for men? And a lot of that has to do with the fact that traditionally the media has portrayed heart disease, a man clutching his heart, as a man's disease. But if this slide will show you, it's actually a disease for women. So just some more statistics, just to kind of nail down how poorly women fare when they have heart disease. If you have a heart attack, 1 year after you have a heart attack, more women than men die. 1 year after a heart attack, 26% of women die, as opposed to 19% of men. 5 years after a heart attack, more women die than men, 47 compared to 36%. What about when they have a heart attack and they're in the hospital? More women die in the hospital after a heart attack than men. 6.8% of women die in the hospital, 4% of men die in the hospital. PCI is a procedure in which people get angiograms after a heart attack, and after invasive procedures for a heart attack, double the amount of women bleed compared to men. At 5 years after the first heart attack, more women have another heart attack than men. 22% women compared to 15% men. And 5 years after a heart attack, more women than men have heart failure, 18% compared to 8% in men. So what's going on? Why do women have poor outcomes when it comes to heart disease? Is it sex-related differences? And in science, sex-related differences have to do with the chromosome. Is it the XX chromosome versus the XY chromosome? Is it the reproductive organs? Is it the hormones? Is that what's going on here? Is that what gives women worse outcomes with heart disease? Or is it a gender thing? In science, gender speaks to gender roles, such as social norms, the social constructs, women being nurturers, providing for their families, making sure that their families are taken care of, and sometimes not taking care of themselves. Or is it something else? So the one thing I wanted to start off with is awareness, which is why we're all here today. So that first graph, that first picture that we showed, this is the mortality of women compared to men and how cardiovascular disease is the most common cause of death in women. So I'm going to take a show of hands here. In 1997, the American Heart Association sent women a survey and asked them if they knew if cardiovascular disease was the #1 killer among women. And so I'm going to see a show of hands here, okay? What percentage of women in 1997 do you guys think knew that heart disease was the #1 killer among women? We're gonna vote. Who says above 75%? Any hands? Who says above 50%? 2. What about above 40%? 30%? 20? 10%? Okay. So the answer is 30%. Yeah. In 1997, when the American Heart Association sent women surveys and said, do you know that heart disease is the #1 killer among women, only 30% of women knew. So here's another pop quiz. 15 years later, the American Heart Association does the Go Red for campaign. Everyone wears a red dress. In February, 15 years later, 2012, the American Heart Association sends women another survey and they say, hey, do you know that heart disease is a #1 killer among women? Let's see a show of hands here. After 15 years of education, what percentage of women now know in 2012 that heart disease is a #1 killer, greater than all of those other diseases? Who says 75%? You're the most optimistic person in this audience. Who says 50%? Who says 30%? There was no change. Who says 25%? 10%. Okay, good. Well, at least it didn't get worse, right? So the answer is 56%. So in 1997, only 30% of women knew that cardiovascular disease was going to be their #1 killer. 15 years later, in 2012, only 56% of white women knew. If you broke it down by race, African Americans and Hispanic women, there was no difference compared to 1997. So what that tells us is we as physicians, medical care providers, the community need to do a better job of making sure everyone is aware that actually this is real and it affects women greatly. And the reason for that, and the reason why awareness is so important, goes back to that earlier slide. We had said earlier that 80% of heart disease is preventable. Until a greater number of women are aware that heart disease impacts them and it's the leading cause of death, how are they going to modify their behaviors to actually prevent this heart disease? So let's talk a little bit about awareness and what the disparities are between men and women and why this is a problem. So when women have heart attacks, there have been a lot of data and a lot of studies that have looked at women with heart attacks, and they realize that when women have symptoms and ultimately go on to be diagnosed with a heart attack, they present much, much, much later than men. One study found that some women delayed their medical provider appointment by 53 hours. They were late. They waited 53 hours before symptoms, before getting help. Men, 15 hours. And what are the reasons for this? This is the the point of a lot of research that's going on right now with the AHA. Is it because women don't know that they're at risk? Is it because they don't think it could happen to them? Or is it because they have these symptoms and they don't think it's heart disease, but it actually is? And there are a lot of barriers there that now in modern medicine we are trying to overcome. Other things associated with delay are old age, being a minority, and having lower socioeconomic class and education. Awareness is actually a two-sided thing. So this talk was actually meant for both the community and for providers, nurses, doctors who take care of women when they come into the emergency room and when they come into the hospital. So the problem is not just with women coming in saying, I have chest pain. The problem also comes with nurses and doctors and medical providers who see women and say, oh, I don't think this is anything. You have nothing to worry about. So when they did research and looked at women who ended up having heart attacks, a lot of them noted that they did not feel like they were taken seriously by the people who saw them in the hospital, in the emergency rooms. A lot of times, these women were diagnosed with depression and treated for GERD or indigestion. And studies show that women are consistently treated less intensely than men. They undergo less life-saving procedures, and less women are treated with guideline medications. This is just a table. I'm just not gonna get into this too much. This basically just shows what the objective differences between men and women are. We have smaller hearts than men. Our arteries are smaller than men. We have a lot of estrogen and progesterone as opposed to men who have testosterone. Menstruation can affect hematologic and EKG findings. And a lot of things are just different between men and women. But what's also more different is how women present when they have heart attacks. So everyone knows what the classic symptoms of chest pain or chest tightness are. And it's essentially a tightness, a squeezing, discomfort in the middle of your chest. And usually it's with exertion. So the way I explain that to my patients is this. Your heart is a big ball of muscle. It needs oxygen. It gets oxygen from 3 major heart arteries. And when you have blockages in those arteries, your heart has to work harder when you exert yourself. So as you walk and as you exert yourself, that's when you usually have symptoms. Chest tightness, shortness of breath. That's typical symptoms. And unfortunately, a lot of women don't present with those symptoms. A lot of women don't present with symptoms that occur when they're exerting themselves. A lot of women have symptoms that aren't a pain or a pressure, but it's sharp and it aches and it's a soreness. Some women say, hey, I'm just really tired. Something just feels wrong. I just have nausea and I'm fatigued, or I think I have this GERD and it won't go away. Some women come in and they have flu-like symptoms. And so it is this difference in presentation of women that sometimes leads to a delayed diagnosis or a misdiagnosis altogether. That having been said, with this slide, the take-home point that I want everyone to know that is that the most common symptom for both men and women in the event of a heart attack is still chest tightness or chest pain. So it's still the most common thing, don't disregard it, but there are a lot of other symptoms that women tend to have. So why is that? Is there a scientific background for why women present differently? I'm just going to make this slide simple and say that in women, this is your coronary artery, and this white thing, it's just a slide showing plaque. And you see how when women have heart attacks, or a lot of women, this plaque is pristine. It's not disrupted at all. So in women, when they have plaque, the plaque erodes. It eats into the pre-existing plaque and it doesn't really disrupt the cap. Whereas in men, this layer, this cap explodes. And when it explodes, it actually narrows the artery. So I'm an interventional cardiologist. When someone has a heart attack, I go in and I do an angiogram and I get that artery open with wires and tubes. When men come in, that artery is usually blocked, 70%, 80%, 90%, 100%. In a lot of women, we go in and we don't see any blockages. And a lot of the times it's because this process we can't see. We don't have the technology to see during angiograms. So why is this important? It's important because there are a couple things with women in heart disease that is different from men, and this is something that both patients and providers should be aware of. When women come in with heart disease, they very frequently are not found to have any blockages. They don't get stents. They come in with a lot of chest pain and angina, and they have a poorer prognosis compared to men. So, non-obstructive coronary artery disease just means a woman comes in for a heart attack, we do an angiogram, we're looking for blockages so that we can fix them, and we don't find any blockages. So if you take all the heart attacks in the world, only 6% of them do we go in and not find blockages. But 40% of all of those cases are women. So here's a case. This talk was meant for providers, and so a lot of these images are for procedures that we do for patients who come in with heart disease. So here's a case. We have a 60-year-old woman. She smokes, she has high blood pressure, she's got diabetes, she's got cholesterol, and she comes in and we have lab markers, and using her lab markers, we find that she's having a heart attack. So we take her to the cath lab, we do an angiogram, and some of you may have had an angiogram, some of you may have friends who've had an angiogram. What that is a procedure where an interventional cardiologist like myself will go in and take a look at the heart arteries, and we find those blockages and we open them up for you. Heart's here, it's connected to the biggest blood vessel in your body called your aorta, which is connected to blood vessels in your arms and your legs. Everything's connected, so that makes our job really easy as cardiologists. We take a needle, we put it in your wrist. Needle in, needle out, no more needles. From there, we bring wires and tubes up into the heart, and we take pictures on x-ray, and we find those blockages, and we fix them with stents. Stents look like coils and pens. They stay in your heart forever. And here is an example of a case. So those are the tubes that we talked about. The tube that I put in from the wrist, and that's what an artery looks like. That's your right coronary artery. And you can see here, it's beautiful. There are no blockages. There's nothing to fix. Beautiful arteries. So that woman came in, she had her heart attack. There was nothing for me to fix. So what do we tell the patient? Do we say, okay, nothing to see here, go home, nothing to do, you're doing just fine, but she had a heart attack, she had chest pain. So this is what's really important. This is a little technical, this is a technical slide, and for the nurses in the audience and the providers, but what a new entity that we are discovering here is something called myocardial infarction with no obstructive coronary artery disease. All that says it's a heart attack where you go in and you don't have blockages in your heart arteries. But we've already gone over with our slides and shown that women sometimes have plaque that erodes and you can't see them on angiogram. But what's important is that you can still die, and there are still poor outcomes with this. If you have a heart attack and we go in and we don't find blockages in your heart arteries, you still have a 3.5% chance of dying in a year. At 4 years, it's 13%. And at discharge, some of the medications that we have our patients take, they're not on. Only 83% of women are discharged on these medications, 64% on ACEs and ARBs, and 84% of patients on cholesterol lowering medications. This just shows bad outcomes in patients who aren't treated with the medications that we as providers usually send patients home on if they have blockages in their heart arteries. So before I move on to the second case, all I'm saying is women tend to present without blockages in their heart arteries. So as providers, we need to take those things more seriously because it doesn't mean that their outcomes are the same. They still can have poor outcomes. And so as nurses and doctors, we need to do a better job of making sure even these women who don't have blockages in their hearts should have the same medications as people who do have blockages. So another case, woman comes in, she has chest pain, and she's young, she's 45, she doesn't know what happened, she has no risk factors. And we go in here and we see, this looks odd, this doesn't look normal. And this is just a separation of the lining of her arteries. And this happens, it's called a spontaneous coronary artery dissection. And it just means that the walls of the artery are separated suddenly. What's important to know here, really for providers, is that the treatment is different. Those arteries will heal. We don't have to do anything. We don't have to stent. We don't have to touch these arteries. And we just leave them alone, and these women will heal. But it's also a very small amount of patients that we as physicians see and need to be more aware of. Case 3, woman comes in, her husband died a month ago, and she has no blockages in her heart arteries, but she's having a heart attack and she's having chest pain. So what does that mean? What do we do for these people? There is an entity called broken heart syndrome or Takotsubo's cardiomyopathy, and 90% of these women, of these cases, are women. Usually they're postmenopausal women. They have some sort of stress or emotion in their lives, and they come in with heart attacks and there's nothing to fix on their arteries, but we have medications that help prevent recurrence because they are at risk for recurrence. So I spent a little bit of time going over statistics, why women have poorer outcomes than men, and took a little bit of time going over some specific examples which are particular in women. But what I really wanted to focus on for most of this talk is risk factors, because the point of this talk is to say that women are at great risk for heart disease. There are some tried and true traditional risk factors that we are all aware of, and there are some new risk factors that I think we should all learn about in order to prevent symptoms. So the first is diabetes. Just see here. So what about diabetes? What is important about diabetes? Women with diabetes have 3 times a greater chance of having a heart attack than women without diabetes. What about women compared to men? Diabetic women compared to diabetic men have heart attacks at an earlier age, and they are more likely to die. Women who are diabetic have a higher chance of having heart failure compared to men who are diabetic. And if you have diabetes, you have a 44% greater chance of having heart disease as a woman than you do as a man. What about smoking? Women who smoke have a 25% higher chance of heart disease from smoking compared to men. Smoking in women, I'll come to this later on, is the ¡1 modifiable risk factor for women. If you smoke and you stop today, your risk of a heart attack and heart disease drops by sevenfold. So smoking is the the biggest modifiable risk factor. And all of my patients that I see in the office, I say, if you smoke, please stop smoking, because that's going to be the #1 thing. What about obesity and being overweight? So in science and in medicine, we have certain cutoffs for what is defined as overweight and what is defined as obese. So there is a BMI calculator that you guys can find online And if your BMI is greater than 30, that's technically defined as obese. So as far as obesity is concerned, more than 2 out of 3 adults in the United States have a BMI greater than 30. And for whatever reason, obese women have a higher chance of having heart attacks and heart disease than obese men. There's a lot of data and research. Is it where the fat is deposited in women versus in men? We don't know yet for sure, but that's something to be aware of, that obese women have a higher risk of heart disease than obese men. What about physical inactivity? So the American Heart Association recommends that everyone get either 150 minutes of moderate exercise a week or 75 minutes of vigorous exercise a week. 10,000 steps a day. So we try to make numbers easy to remember. 10,000 steps. If you have a Fitbit or an iPhone, it tracks your steps, 10,000. And we also recommend strength training 2 times a week. The problem with physical inactivity is that the data shows women tend to be more inactive than men. Above the age of 75, 52% of women are physically inactive compared to 40% of men. And younger than the age of 75, 33% of women are noted to be physically inactive compared to 25% of men. High blood pressure. We all talk about high pressure. All the primary care physicians, all the cardiologists, we know that women over the age of 50 have a higher incidence and prevalence of high blood pressure than men, and it's less well controlled than men. What about high cholesterol? Having high cholesterol increases the risk of heart disease among women by 47.1%. It's great. Like, if you have high cholesterol, that is, aside from smoking, the second best thing that you can do to lower your risk of heart disease. The problem with high cholesterol is, as a doctor, I talk to all of my patients about trying to get them on medications for cholesterol. Everyone says no, because everyone watches TV and they see all these side effects from cholesterol medications. But that's why the data shows that only 45% of all people who should be on a medication for cholesterol are actually on it. So a few of the things I've already gone over: diabetes, smoking, obesity, not being active, high blood pressure, high cholesterol. Those are things through the years we've all heard about. Through the years, through your visits with your nurse practitioners and your doctors, we've always harped on. But starting for about 2 or 3 years ago, we've identified a couple of other things among women that may contribute to this increased risk in heart disease that is really important for us to all be aware of. Preterm delivery. So what does having a child preterm as a woman matter with your heart? Well, apparently it does. So preterm delivery is defined as delivering a child less than 37 weeks of being pregnant. 5 to 12% of all pregnancies in the world are preterm. For whatever reason, and the data is still out, there's still active research into this. If you have a preterm delivery, at 10 years, you have a higher risk of having a hospitalization for a heart disease and worse long-term cardiovascular outcomes compared to women who've never had a preterm delivery. What about pregnancy and high blood pressure during pregnancy? We all know that high blood pressure plays a role in heart disease as we're older, but what about when we're pregnant? So just some definitions. High blood pressure during pregnancy is significant if you have it after 5 months of being pregnant. If you go into pregnancy pregnant, that doesn't count. But if you develop high blood pressure during pregnancy after 5 months, then it matters. High blood pressure after 20 weeks can lead to a severe form of high blood pressure called preeclampsia. Preeclampsia is high blood pressure after about 5 months of being pregnant, having protein in your urine, and having other organ dysfunctions. And when women have preeclampsia during pregnancy, they have a 3.7 times greater risk of having high blood pressure 14 years later. They have a double the risk of heart disease at 12 years. They have almost double the risk of a stroke at 10 years. And they have almost double the risk of a blood clot in the legs at 5 years. I'm gonna skip this here. What about diabetes while pregnant? If you are diagnosed with diabetes after the first trimester, you are at risk for a lot of things. One of those risks is developing diabetes later on in life. You have a 7-time chance of having type 2 diabetes later on in life. And even if you don't develop diabetes later on in life while not pregnant, just having diabetes while pregnant increases your risk of a heart attack by 4 lifelong and increases your risk of a stroke by 2. While pregnant, usually people gain about 20% of their body weight. Weight at 1 year really predicts how you do after pregnancy. And if that weight gain doesn't come off by about a year, it is associated with worse cardiovascular effects. Other diseases that can contribute to heart disease, that is especially true in women. Diseases such as lupus and rheumatoid arthritis. If you have inflammatory disorders like rheumatoid arthritis, you have a 2 to 3 times higher risk of a heart attack. You have a 50% higher chance of having a stroke. If you have lupus, your risk of a heart attack is 9 to 50 times greater than the general population. Why is this important? It's important because these autoimmune diseases are mainly female, predominantly female. There are 9 women with lupus compared to every 1 male. There are 2.5 women with rheumatoid arthritis compared to every 1 male. So we're starting to see a picture here about women and heart disease and these other disease processes that tend to predominate in women that also impact cardiac care. And these are things that we're just discovering in the most recent 2 to 3 years. So let's talk a little bit about breast cancer. I left this slide up here because among cardiologists, breast cancer, we always feel like we're competing with breast cancer because October is like pink month and it's breast cancer awareness month and everyone wears a pink ribbon. And the thing with breast cancer is at every age in women, every age group, deaths from heart disease far, far, far outnumber deaths from breast cancer. In fact, the mortality for breast cancer right now is 4%. 4%. It's nothing. I mean, it's awesome. It's awesome that what the awareness has done. So what is it about breast cancer and heart disease other than fighting to make the public aware of their risks? A lot of women have breast cancer and a lot of women get radiated for breast cancer. What is starting to come out now is we're finding that the amount of radiation you get when you're treated for breast cancer is directly proportional to your higher risk of heart disease at the end of that radiation. So radiation is measured in units called grays, and with every higher gray that you get of radiation, you have a 7.4 higher chance of having heart disease. These risks are seen up to 30 years after radiation. There are women who, especially who get radiated over their left breast, it's where your heart is, And those women in particular have been found to have premature coronary artery disease at much higher rates than women who get radiated on their right breast. This is just a graph showing your proportion of heart disease increases exponentially as the amount of radiation that you get from breast cancer. Other things, chemotherapy can also lead to heart disease, and so some cardiologists will do stress tests to make sure they screen patients for heart disease. And finally, one of the newer non-traditional risk factors, especially prevalent in women, is depression. We already talked about the broken heart syndrome and how that can impact the heart. Well, newer research has shown that younger women have higher rates of depression, but when they have heart attacks, they also have higher mortality rates compared to men. So what is the point of this talk, and what is the point of these statistics and these facts? It's really to make people aware so that they can move towards prevention. So what I always recommend in patients, friends, family members is to always establish yourself with a nurse, a doctor, a provider, a cardiologist, a primary care physician, family med, who you can sit down with and who you can address diabetes and smoking habits and your weight and your physical inactivity and blood pressure and cholesterol. What can we do outside of not getting pregnant as women that will help us with heart disease? And it's sitting down with a provider early on so that they can help with these risk factors before they become problems. So prevention. The American Heart Association recommends a DASH diet, which is a low-salt diet, but studies show that a Mediterranean diet, which is full of olive oil and canola oil and vegetables and legumes and fish, are associated with lower risk rates of heart disease. The American Heart Association recommends you getting 7 hours of sleep a night. Decrease the stress, do the yoga, exercise, go to the gym. And what's important is, especially for younger women, is alcohol. So moderate alcohol intake is literally defined as 1 to 2 drinks a day as women. Anything higher than that, 3, 4 drinks, increases your blood pressure, increases the fats in your blood, and potentially increases your chances for bad heart rhythms and heart failure. So we started off with this slide, and this was me showing you that from 1979 to 2000, heart disease, #1 killer for women, was rising. For men, it was dropping. This is what has happened from 1979 to 2011. So as you saw, we stopped the chart there. Rates of death for women were climbing. This was a problem. And then what happened? What happened was the American Heart Association said we need to make people aware, especially women, of their risks. We need women to pay attention to their bodies, to their symptoms, and to their risk factors, and to modify them. And so from about 1997 to 2011, rates have finally started to drop. They're still higher than men, so there's still work to be done. I mean, women are still getting pregnant, so I mean, that's a risk factor that we can't escape. But we're on our way. So this was a lot of data focused, and but what I really wanted to leave everyone with as a take-home point is that heart disease is the #1 killer of women. 1 out of 3 women in this room, 1 out of 3 women at church is going to die of heart disease. And it actually claims more lives than all forms of cancer combined. Given that fact, we need to do everything we can to prevent heart disease from occurring, because when they do occur in women, for all the reasons we tried to identify, women do a lot worse than men. Okay. Any questions?
I need a drink after this.
Only 1 to 2 drinks, right? Above 2, yeah.